si estás ahí. Me gustaría la opinión tanto de los doctores Aragón, Steinberg y la doctora Musso. Javier, si querés podés empezar a compartir tu pantalla.
There we go. It's okay. You can see my screen.
Yes.
I have some problem with my internet signal. I have to change to switch on my iPhone. So just tell me if everything is okay. So I have to switch.
Viene todo muy bien.
Okay, thanks. So we have this male patient, 75 years old, diabetes type 2. 20 years ago, he had his diagnostic of diabetes. Not controlled, is a patient from another province here in Argentina. They came to us to find a kind of a second opinion on his dry hallux necrosis. It was, he has a mild trauma 5 months ago. So here we have the patient. No soft tissue infection, nor osteomyelitis. As we can see on the pictures, he has severe peripheral vasculopathy. He only has this Doppler of the study of vasculopathy. He has occlusion of anterior tibial artery and also posterior. And the peritoneal was 90% of obstruction. So on physical exam, we have dorsalis pedis pulse negative, and the posterior tip is kind of a 50%. It depends on the examinator. So we have some mild neuropathy, and he has an indication of another surgeon of major amputation, another hospital. He's from Corrientes. He's north from Buenos Aires. He has this index from a ankle and brachial index, 0.89, and is the same as the Doppler. We have the same information. So we jump directly to we indicate an interventional angiography directly to get a better flow. Some other surgery, for some orthopedic surgery. So the vascular surgeon just could open a little bit the peroneal artery with a balloon angioplasty. He had 2 lesions over there, and then we will see how we get to this tiny better blood flow. We have here a deep femoral artery, how we jump directly to the knee. And then
never a good sign when the vascular specialist says the best they can get you is a perineal. That's never a good sign.
Yeah, he told us it's not the best patient, but we say this is the patient for us. We will present this one. So this is what we got. We got a 10 to 15% of increase with some collateral circulation and a tiny better peritoneal and plantar arch. So the first question would be for Carla, because we have a patient that is not properly treated and studied. So Carla, how do you, we don't have any studies on metabolic studies, so what would be your approach in this patient?
Well, the first step will be to have a lab to know the metabolic control of this patient. And if I already know that the patient will go for a surgery, I will prepare him with insulin. We know that is the best way to get to target in this patient, and also it's known that a good control is better for surgery in terms of healing after surgery. So definitely I will treat him with insulin.
Perfect. So here are our concerns on this case. Can it be another concerns? It depends on what's your opinion of John and Javier also. We have here a decision-making process. What do you need to make an indication on this patient? Whatever surgery. So I put some examples. Sure, you have another one on mine. So we have the clinical scenario only to make this indication. for surgery, the clinic scenario plus the vascular approach. So here we have another studies to know what will be the surgery needed in this patient, infrared thermography, and angio MRI, other studies, or a different approach. So we will jump directly to this first decision-making process, and then we jump to surgery. So I will start with Javier. So Javier would be, how do you approach this patient with these studies? You need some extra studies? You go directly to surgery?
Yeah, this is a very common situation in our country. Many surgeons indicate a major amputation without performing any vascular studies. For me, it's clear that a dry gangrene in a diabetic patient is an ischemic patient with critical ischemia. In these cases, we perform directly angiography, and go the patient to the operating room, trying to perform angioplasty. We don't perform only Doppler study in our consultation, but the clinical evaluation is critical. A diabetic patient without distal pulses with dry gangrene is a critical limb ischemia. There is another type. And without infection, because sometimes necrosis may be a consequence of necrotizing infection. But in this particular case, no infection, dry gangrene without pulses is a critical limb ischemia. This patient needs an angiography.
Okay, so Javier, you are happy with our vascular, or we will need another vascular surgeon to repeat the surgery? What do you think about?
I have a problem with some vascular surgeon in my team. I have endovascular radiologists because they perform angioplasty very well. If they are not able to perform angioplasty, then we send the patient to vascular surgeon to open bypass. But the first step in our team is performing endovascular approach.
Endovascular. Perfect. Do you need some extra study, or you can go directly to surgery?
Directly to surgery.
Okay, perfect. I will jump to John, and then we just move on the case. John, the decision-making process would be?
Yeah, so I would completely agree with Javier that angiography is done without delay, and you guys have done that. But the problem is that your angiography didn't give you much, and you got a perineal, which is not enough to sustain any surgery at the first ray, and anything you do to that foot is most likely to fail. So I would push for a repeat angio, or I would push for a bypass. I don't think you really need much more clinical diagnosis, but you need more blood flow. Because right now, if you do anything surgical, it's destined to failure, and anything would be guesswork as to a first ray versus a TMA versus going proximal. So if this is already your trusted vascular surgeon and this is the best you're going to get,
it's the best. But not in this case, there are cases and cases.
Yeah.
No, she's very well. She's very good.
If the case has options, then I would go to vascular surgeon B and C and get more blood flow. But if this is already your trusted partner and they say, no, this is the best you can get and everything else is calcified, then you have to have a real detailed discussion with the patient to say, this is the best we're going to get. And we have the option A is to leave the dry gangrene alone and not do anything surgical if it's not infected. Option B is to try a midfoot amputation, which has a high chance of failure. Or option C is to go and agree with a below knee or above knee amputation. And I really would let the patient decide that. If I felt the blood flow was so poor, I would say, maybe there's a 20%, 30% chance that we could do a first ray or a midfoot amp and have it succeed. But that's something the patient and the family have to really be involved in.
Okay, John, perfect. So you jump to the second question. So I will come again with Javier. Your indication for surgery would be, Javier, which one?
Oh, depend on the outcome of the revascularization. Depend. I agree with John about the three options. If revascularization is successful, I will wait to evaluate the clinical course of the toe, because sometime after revascularization, the dry gangrene become wet gangrene, and we have to amputate. Sometimes it's very difficult to perform only toe, big toe amputation, because if in this case the gangrene was in the second, third toe, I perform minor amputation. In case of big toe gangrene, maybe I decide to perform a transmetatarsal amputation. I think it's more functional. Probably is best outcome, minimizing the risk of reulceration. I don't think if John is agreeing with me.
Yeah, very much so. I think TMA would be the way to go versus a first ray amputation.
So it will be minor amputation, let's say some tiny difference, but would be a minor, for instance.
Yeah.
So we choose also a minor. We have in the severe patients an experience of 50-50. When we risk in these patients on a minor amputation, we have to jump for another one, and then the other 50% will do well. But it's because we have these problems in Argentina, the patients come very late. So we have plenty of this. So we did a first ray amputation. So it's a Mauricio's patient. So he had a VAC, but I don't have the, because I think he left the wound open for some days. He had VAC, and then he finally healed in 3 weeks. So this is the patient we finally healed. But we had some extra problems after, and then we have this. It's the same patient. 8 months after, he had a second metatarsal plantar ulcer. We have this test done. As Javier said, we did the prop to bone was negative. It was only the flexor tendon, but not the articulation or the bone. We have the lab test was negative for infection. And then we have, sorry, we didn't have here an MRI, was negative for edema or osteomyelitis. So this is the same case. Now,
Mauricio, I hope you did attend to Achilles lengthening at the time of that first race.
That would be
at Georgetown. I hope you did.
I know we will fight. I know. But the fight will be in a few minutes. Just wait, John. We will fight.
One more.
So we have now kind of a different indications because he finally healed on the first first ray amputation. So this is some of the examples again. I will this time I will begin with John. John, you agree with these patients with these treatments?
Yeah, so
we'll jump.
I'm very, very lucky to heal the first ray amputation. I'm amazed that the vascularity was strong enough to heal, but that's good news. And we've proven Javier Aragón-Sanchez correct in saying that TMA probably was a more functional procedure because now we have a transfer lesion to the second metatarsal, very predictable. I guess I would not do a second metatarsal resection. If a tendo Achilles lengthening was not previously performed, I would do that immediately. But if a tendo Achilles lengthening was already done, then I would be encouraging the patient to progress to a transmetatarsal amputation.
Okay, just jump another minor amputation. Okay, Javier, what's your opinion?
Yes, I would like you to show the X-ray again because it's very interesting to comment some cervical.
Sorry about the quality of the X-ray. We have this one.
For example, this is the severe consequences consequence of using a mechanical scissor to cut the bone. We always use a power saw to osteotomy. In this case, you can see the first metatarsal stamp is with a pencil. It's like a pencil, because this is due to using bone scissor. I always use the power saw for performing osteotomy in such cases. And in the second metatarsal head, there is a location of the metatarsal phalangeal joint. In this case, please go to the next slide. I use in this case on second metatarsal phalangeal resection with tendon Achilles lengthening. Is my option. Or second option is performing a transmetatarsal amputation, because I think it was the best option in the first time.
That's interesting, because we have the same patients, and the portfolio of treatments is kind of a universal, and every surgeon will do everything different. So, but it's the same patient. So we decided to go ahead and make another amputation. So we have some experience of 10-year experience of percutaneous surgery for hallux valgus and midfoot and also hindfoot. So we did what an Italian guy named Carlo Bis published 2 years ago, and he recommended a mid-shaft percutaneous MTC osteotomy, and to include also the second, third, and fourth metatarsal, and a local debridement, not to bone. And then this is the surgical picture on my right. And then this will be the osteotomies. So I will need the opinion of both Javier and John. We decided to leave a subluxation on the toes. So if this patient was not vascular, is really a problem. But it's a problem for you to leave this empty metatarsophalangeal joints luxated, or it's not a problem for you? So I would need a John answer.
I would agree. If you're going to go this route, you can leave the second MPJ alone, but because it's too high a risk to dissect that vascularly, you'll probably cause an ischemic toe. But this is a short-term gain and a long-term loss. You're just going to keep transferring these pressures around. Now your fifth metatarsal is going to be a concern. I like the intent, but I wouldn't do it. I'm not a fan of letting these metatarsals float because the pressure is going to land somewhere. I would have considered pan-metatarsal head resection, but again, that's very risky from a vascular standpoint because you could end up with ischemic toes from that. So I would still vote for TMA instead of doing this.
Okay. Remember, it's a Mauricio's patient, it's not mine.
That's why I'm being real hard on him.
Okay.
He knows my opinion.
Oh, you can hit him, not me, please. So I would have done the same. Yeah, sure, for sure. So this is the patient, 3 months and then 4 months. And then it finally healed, 4 months and a half. Yeah, we agree with you. It can be a short time solution, but we try. We don't know yet what will happen. Javier, I will need your opinion about this. So you agree with John? It's a short-term solution, or he can be fine, let's say, 2 or 3 years from now? What's your opinion?
There is not so much experience with minimal invasive surgery in diabetic foot problem. This is this paper is very interesting, but we need more information about the long-term outcomes. Probably this, I agree with John, this is a temporary solution about this patient. The patient have a real neuropathy, not mild neuropathy, as you say in the first slide, because if not, he didn't develop this plantar ulcer. Probably the patient will have pressure transfers during the next future and will develop a new plantar ulcer.
Mauricio, can you please show us this patient in 1 year, please, to the panelists?
Next year I will show you
Do
midterm
so,
results.
please.
He's only going to remember to show it to us if it's successful. If it's not successful, he's going to forget, but that's okay.
Yeah, that's for sure.
Well, send to Washington, D.C. the patient. So this is the final X-ray. So we have this subluxation and this huge callus from these osteotomies. So we will see. This is the final solution for this patient. So this is the second patient. It's a 28-year-old female, diabetes type 1. 7 years ago was the diagnosis of the diabetes. She has last year a low energy foot trauma with pain and progressive deformity. Now we have a mid-foot charcot neuroarthropathy. With this, we have no so much erythema here, but it was swollen. It was much red, this foot. Then we have Eichenholz 1 and the classification of loose shown that is for midfoot, also a 1. Then we have this index with a echo Doppler normal. And then the problem would be here. We got this patient, also it's not from Buenos Aires. We have this patient with this hemoglobin, glycoside hemoglobin 13.1, and then at that time she began with insulin. So at this time we wait to get this Eichenholz 3, and the question would be for Javier and for John: have you done surgeries on Eichenholz 1? Because we know there are some studies published that recommend to do surgery on Eichenholz 1. So I will begin with Javier. Javier, have you done these surgeries on this stage when it's sweat, red, swollen, and all that clinic from this stage?
No, we always recommend surgery in cases of Charcot foot, in cases of chronic Charcot disease. When the patient develops foot deformities producing ulcers. If not, we manage the patient with a conservative approach. But I think it's very interesting, this patient, not for me, but Dr. Musso, because these are the severe consequences of the bad metabolic control in a patient with only 7 years of diabetes type 1. Because the patient had developed a severe neuropathy. The consequence of this severe neuropathy, is a severe Charcot disease producing probably in a severe deformity in the future. For the reason, the key of this patient is before developing the Charcot. The patient need a good metabolic control to avoid this type of complications.
Perfect.
Yes, of course. In this patient, obviously the bad control is that came into this situation. But the thing is that now we need to start an intensive insulin treatment. With he already has a bolus, but we need to put rapid insulin, and we really need to get this patient under control before the surgery. That's what I recommend in this case.
Perfect. John, what's your opinion? Have you done this stage surgeries?
Yeah, great point, Javier, to talk about this medically. This really is primarily a medical concern first, because if you don't address the medicine of this, then you're just going to be chasing yourself and having complication after complication. But I would say yes, we do occasionally, in very select cases, operate in acute Charcot, but not on the bone, only at tendo-Achilles lengthening. I will take a lot of these early stage Charcot and do a tendo-Achilles lengthening just to try to prevent more damage while we're treating with casting and offloading and medical management. So I agree, we would never do the bone reconstruction now, but I would suggest consider a TAL just to help. I consider TAL really conservative care for this, but use that to help your offloading while you're trying to get the patient medically managed.
Okay, it will be a two-stage approach.
Yeah.
Tendon now and then just wait. Okay.
I
So
agree.
We wait. So we wait, and then we do this the treatment for stage 1 edge and holes, and then we mix kind of offloading and water wood and physical therapy also. Then we jump to edge and holes 3. Then because of Carla and her team, we have another patient. Now we have 11.1 and 8 months after. So it's kind of a different patient. I think a better patient to do surgery. And then this is the X-ray comparative. And then there will be some of the options. Again, you can talk about other ones. So which one can start with these questions? Because I forgot where I began. So I began with John, with Javier.
Let's see. Javier went first on the first part, so I can
Okay,
go
perfect. So
first.
John.
Any of these are viable options. I think the key thing is, what is it that you as a surgeon are comfortable? Is this a case that you do with frequency? And if so, is this similar to the level of management that you would provide? So clearly this midfoot will have to be excised. And then how you reconstruct that, you could beam that, you could superconstruct it, you could external fix it, whatever it is that you are comfortable and have the experience doing. I don't think there's necessarily a real right or wrong answer here, as far as that. We fight over fixation so much about, oh, I would have done this or that. Honestly, I think if you whatever way you can put this back together for that particular patient in your practice, I would not argue about really any of those techniques.
But which will be the indication in Georgia, where you work on this patient?
So we are going more and more to beaming and supplementing the beam with a superconstruct plate of the medial column. So aggressive medial column plating, and combine that with the beaming. And then I would say still about 30–40% we do by external fixation. It's becoming, the question I think really is, are you obligated to two-stage this still? I guess essentially it'd be three-stage, right? Because your first stage was just conservative care. And are we going to do 2 more surgical stages? Meaning, are we going to clean it up and external fix it first, and then come back a month or 2 later and do the internal work? My new partner here, Dr. Advez, is an advocate oftentimes of clean all this up and external fix it, and then come back and do the beaming and the plating afterwards. But I would say right now we're about 2/3 of the time it would be all internal, and 1/3 of the time it would be external.
Okay, would be beaming plus plates would be the first option. Okay, Javier?
Oh, we don't have a lot of patients with chronic Charcot. We just indicate the surgery in cases of the patient develop ulcer, or there is an unstable foot. In this case, it's my orthopedic surgeon, because I don't perform this type of surgery. I am a general surgeon. My orthopedic surgeon preferred external fixator.
External fixator frame. Javier, can you explain which one? Because there are some computerized frames, really expensive, or really the cheapest one. Which frame would be the option, if you know?
I don't know what say, because they really perform this type of surgery.
Okay.
I don't have a lot of experience in charcot food, only in conservative approach.
Okay. The conservative approach in these patients is fine for you, or you will done another? Let's get back to this one.
No. Okay. In the acute phase, we indicate always a total contact cast. Sometimes we complement the total contact cast with Achilles tendon lengthening, as said John. But in this patient, for example, if the patient does develop a plantar ulcer, we use a customized insole and customized shoes. If the patient develops ulcer, we talk with our orthopedic surgeon team about the best way to reconstruct the foot, but don't perform because we don't have a lot of experience in the charcot foot reconstruction.
Okay, total contact cast would be the first option. We don't have really the staff to do that yet. We like it, but it's difficult to manage this in some patients that already have some ulcers. So I will get to John to this question also. So John, the treatment here for this phase in Georgetown would be which one?
Meaning outside of surgery at this point, or whether we would?
Yes. To wait until stage 3, the treatment.
Yeah. So I would still say, even though you got the hemoglobin A1C down to 11, we really would want to get it down to 8 or 9. You've done a lot of work, but it's still a little ways to go. You've got a closed skin envelope. I would feel very comfortable operating as long as the patient wasn't threatening an immediate reulceration. So I think, yes to operate, but if you had the time and the patient was reliable, I would wait to get the A1C down to 8 or 9 would be much better.
Yeah.
Yes. In this patient, we have some extra pain and difficulty to walk. And then we discussed this with Carla and her team. And basically we pushed them to do surgery at this stage because of the clinic of the patient.
Yeah.
But the patient was getting even better with her insulin. So this lab is getting down. And then what will finally happen that they finally got to it. So I will show what we've done.
Okay.
The thing is that to change the hemoglobin A1C will need like 1 month or 2 months. So the patient was really under a very good control with a monitor. So that's why we said yes, because we already know that the patient is fine. Even when the hemoglobin A1C is 11, it will take months to change that. So after that, the patient was much better.
So a question for both Javier and John, would be this lab on 8 or 8.5? Because there are some studies that say 8 is better than 8.5. So Javier, would be your preference would be 8 or 8.5?
8.
8. John?
Yeah, if you follow Dane Wukic's work, then yeah, it would be he has a split opinion. It's below 8 or below 9. So we certainly would prefer to have it below 8, but I would there's good literature to support anywhere below 9. So, and I think you Dr. Musso pointed out too that it's the trend and the patient buy-in and the fact that things are improving rather than worsening that makes me feel safer as a surgeon to start engaging in correction surgery with that patient, knowing that things are going the right direction.
Okay, perfect. So we've done similar to John. That's why Mauricio came from Georgetown and he says, John would do that. So we will do that. And then what happens is this.
So we agree on this one.
Yeah. So we had some experience with supercontraction, so just with plates, but we have a failure rate kind of a 60% because they fall down on the midfoot. So we jump to we call kind of a hybrid superconstruction, beaming plus medial plate. And then our outcomes are better. We have now kind of 4 patients I know we didn't follow some publications on that, but I think we will. This is the future. Or we have the frames, or we have this kind of a hybrid software construction. John, do you agree with what we've done?
Yeah, very nice work, except on the lateral view. I would want a little more correction in the...
I have a weight bearing, let's say, the final. So the insulin this went down to 8.1.
Yeah, that's great. I just,
this is it, right?
Yeah, I would just want more correction here. There's still a little too much bone plantarly that needs to be addressed.
Okay.
So I like the hardware, I like the construct, and the medial column alignment is perfect. I just would have either resected more of this bone or worked longer to get that mid-tarsus relocated prior to the fixation.
Okay, perfect. Javier, some other considerations?
No, great surgery.
You're learning here now.
Great surgery, congratulations. I would like to see the foot, but congratulations, because the radiological reconstruction is perfect.
We have some edema. This is a 6 months period from surgery. We have some venous edema, but with almost no pain on a treatment with the phlebotomist. So those will be fine. Thanks. I would like to thank both and also Carla for your time. And I will just leave Mauricio for final considerations. So thanks both.
Thank you.
Muy bien, bueno, muchas gracias a todos por participar, a todos los espectadores que estuvieron viendo muy atentamente el seminario, y muchas gracias a todos los participantes, a los oradores, a Javier, a John, a Carla, y al otro Javier, al mío, que lo veo siempre. Thank you very much for all of you. I hope to see you soon, all of you, maybe next year, here in Buenos Aires. We are planning to do some presence conference, so maybe we are all here in Buenos Aires next week.
Great.
Next year.
Yeah, or next week is good too. Let's do it.
Okay, well, thank you very much. We have a lot of congratulations here on the Q&A for all participants. So if you would like to read it, it's okay. And later I will get you the video. Okay?
Okay.
Perfect.
Thank
Thank you very
much. Bye. See you. Thanks.
Bye. See you.
Bye-bye.
Bye, John.